Okay, alrighty. Let's hope that goes away here.
Yeah. Hi, everyone. Thank you for joining us. Welcome to the sixth episode in our new webinar series, Oncology Hour. I'm Fiona Evans, and joining me this week is Dr. Sandoval, who is the assistant member of the Department of Malignant Hematology and Cellular Therapy at Moffitt Cancer Center. As you know, I work for Massive Bio, and we are a concierge clinical trial enrollment service where we connect patients to clinical trials. We're here today with Dr. Sandoval to discuss lymphoma and answer any questions you may have about lymphoma and how they relate to clinical trials. We know there are always lots of questions surrounding clinical trial enrollment and lymphoma in general. So for this week, if you have any questions, please note them in the chat area, and we will try and answer them as best as we can. Before we begin, Dr. Sandoval, could you tell us a little bit more about yourself?
Yes, Fiona, thank you very much for the invitation, both you and Massive Bio. It's a pleasure and an honor to join you guys here today. So, yes, my name is Jose Sandoval. I'm an assistant member at the Department of Malignant Hematology and Cellular Therapy at Moffitt Cancer Center. But I'm actually located in South Florida instead of that in Tampa, where our mothership is, where quote unquote big hospital is there. I work in a healthcare system that is called Memorial Healthcare System, right next to Miami in the Fort Lauderdale Broward area. And I only see patients with malignant hematology cases, but it's more specifically lymphomas. And I also deal with stem cell transplants and CAR T cell therapy and other forms of cellular therapy.
Great. Well, thank you. Excuse me. Thank you for everything that you do for cancer patients, and thank you for joining us today. So we'll get started with our first question, and that is, what is lymphoma? Can you tell us a little bit about it?
Yes, absolutely. So lymphoma, it is a malignancy, or it is a malignant cancer that is derived from specific cells from our body that are called white blood cells, right? These white blood cells, they're our own personal army. So there are our they make up part of our immune system, or immunologic system, that nowadays with this pandemic is very, in vogue, I would say. These cells, white blood cells, they have different components. One of the most important components, or cellular components, are some cells that are called lymphocytes. These lymphocytes, these lymphocytes, they are specialized cells of the immune system. They have different functions. There are multiple type of variations of lymphocytes, but we can identify three most important lymphocytes. I would say that are we call it B lymphocytes, or B cells, T lymphocytes, or T cells, and natural killer cells, or NK cells. All of those cells, all of us, we have these cells, and they live in perfect harmony in our body. And they actually go all around our body, protecting us against, infections. They also are involved in inflammation, in allergies, and even in cancers. They fight cancers per se. So they go all around our body. They're born in the bone marrow. But they mature in different parts of our body, like in the thymus. It's a gland that we have when we're kids, and then eventually it devolves and when we are adults. But also, and most importantly, in some what we call secondary lymphoid organs, most importantly in the lymph nodes. Mm-hmm. Also, they can be on the spleen, some areas of the liver, and then some other lymphoid tissue that can be in multiple parts of our body, even in our gastrointestinal tract, in our skin, even in our central nervous system. So these lymphocytes, they usually run fine, like a really well-oiled machine. But suddenly, there are different I would say triggers or injuries that can occur to them that makes them reproduce without a proper control from the body, and the sort of quote unquote the checkpoint of our or homeostasis of our body can not longer control their growth, and that's when you create cancer of these lymphocytes. Mainly lymphoma is cancer. It's a malignant tumor of these lymphocytes, could be B, T, or NK cells. We're going to talk a little bit more about that later on, that are reproducing on multiple areas of the body, but especially on the lymph nodes, okay?
Okay.
But also in other parts of the body, like skin, gastrointestinal tract, so forth and so on.
Okay. And
Mhm.
how does that differ from a solid tumor cancer?
So it differs in multiple ways, right? For example, the type of cell are totally different, okay? And most of these patients, even though they don't receive treatment right away, as you're gonna see, that is a difference between these particular cancers and solid tumors. Some of them you don't have to treat them, and some of them our patients will never receive treatment for them, and they're going to be long, healthy lives with no other issues. That's one major difference. The other difference is that in a lot of cases, we don't use surgical procedures or surgeries to take off the tumor per se. Mainly at the beginning to do a biopsy and determine the appropriate diagnosis, but
Right.
afterwards, most of the time, the great majority of the times, they're not amenable of just a resection to be cured. Okay, most of
Okay.
the time they need systemic therapies when they're in different locations. Systemic therapies like immunotherapies, chemotherapies, or if they're very localized, radiation therapy. And another thing is that a lot of these tumors, since they are disrupting our immune system, right, they
Mhm.
also are involved with a lot of immunosuppression. So our patients are very susceptible to several types of different infections, and sometimes even without even starting treatment. And
Okay.
there's a lot of other differences, but those are probably one of the most
Those are the
important ones.
basics.
Mhm.
Yep. Yep.
There's
Okay.
another one that I forgot, but we can talk about that later. But the staging is a little bit different because I got to tell you, this is really fast. Even
Mhm.
if our patients have a stage 4 disease, they
Yeah.
still can be very well treated, and they still can be cured in a lot of times, depending on the lymphoma.
Oh, excellent. That's very
Mm-hmm.
important and good to know. Thank you.
Mm-hmm.
So what are the different kinds of lymphoma?
Okay, that's a very important question, but a very broad one. So the
Okay.
way I explain it to my patients is that we consider it in two ways, right? First of all, there are very two big groups. Okay, there's one that we call it Hodgkin lymphoma. That is a
Okay.
very small type of lymphomas. Okay, and they're always coming from B cells or B lymphocytes. Those Hodgkin lymphomas, they will always come from B lymphocytes. All right, those
Right.
are only 5 types of those Hodgkin lymphomas. Okay,
Okay.
that's one group. The biggest group and the more common one, it's one that we call non-Hodgkin lymphoma. It's not a very original title, but one is Hodgkin, the other one not Hodgkin. But in the not Hodgkin group, we have more than 60, 70 diagnoses nowadays recognized by the WHO. And why are there so many? Because they come from different cells. The less common ones, that are usually less than 1% or less, comes from those natural killer cells. The ones that follow comes from T lymphocytes or T cells. Okay, that's around 10 to 15% of all non-Hodgkin lymphomas. And the most common ones, they come from B cells or B lymphocytes that are called B cell non-Hodgkin lymphomas. There are about 80 to 85% of cases. All right.
Okay.
And then when we go to the part of non-Hodgkin lymphoma per se, the B cell lymphomas, right, that they're the more common ones,
Mhm.
we can divide them in also two big groups.
Okay.
One of them, we call it the aggressive B cell non-Hodgkin lymphomas, or the ones that are fast growing lymphomas, right?
Okay.
Those are the lymphomas. Those are actually the most common lymphomas, and the most common one is called diffuse large B cell lymphomas. We will talk about that later. And the importance of these lymphomas is that they come very fast. You will develop symptoms quite fast, and the patient can get quite ill in a quite fast, right? In less than 3 to 6 months. But
Wow.
importantly, a lot of them actually can be cured, even if they're stage 4. So more than 60, 65+% of patients can get cured nowadays.
Oh,
In the
great.
in the other spectrum, we have the B cell non-Hodgkin lymphoma that we call indolent lymphomas, that they're slow pace or slow growing B cell non-Hodgkin lymphomas. From those, the most common one is called follicular lymphoma. That we will talk about that later. But the characteristics of these guys is that they grow very slow on time, and
Okay.
a lot of times, actually, even in patients that they have a stage 4 indolent or slow pace growing lymphomas, a
Hmm.
lot of times we don't need to treat the patients right away.
Good.
Okay, and why is that? Because unfortunately, a lot of these tumors we cannot cure. Okay, we cannot treat them and for them to never ever come back. Most of them, they become a chronic illness that we are able and very capable of putting them in remissions and very deep, complete remissions. But a lot of times they have the tendency to come back. Okay, and of course, there are different exceptions, but they're in between. There's
Hmm.
one more category that is in between, has a little bit of both parts of an aggressive and an indolent.
Hmm.
The Some people call it intermediate grade. That
Okay.
doesn't really exist, but we see it like that. That is called mantle cell lymphomas. That is only
Hmm.
around 6% of all those B cell non-Hodgkin lymphomas,
Oh, okay.
and we can control it really well. But unfortunately, it tends to come back, and when it comes back, sometimes it tends to be quite severe and it's hard to control. But we can
Okay.
talk a little bit about that.
Okay. Okay. That's very interesting and good to know that there are lots of treatments available and good
Mhm.
outcomes. The other, I know you touched on this briefly, but could you explain a little bit the difference between Hodgkin's and non-Hodgkin's lymphoma?
Absolutely. So Hodgkin lymphomas. Let's start with that because it's a sort of like a more rare disease,
Hmm.
but it's very interesting from the standpoint of clinical trials. And it's something that at
Okay.
Massive Bio we will enjoy this conversation because of the purpose of the goal of this podcast or this presentation. So Hodgkin lymphomas, there are only 5 types of those Hodgkin lymphomas. They're very characteristic. The name Hodgkin is the name of the physician who described this in the 19th century, but it's very characteristic because when you look at it in the microscope, it has some characteristic cells that are called Ritz-Stenberg disease. It look like 2 owl eyes. They're very interesting looking cells, if I might say so.
Okay.
But it's also very characteristic because in the tumor per se, when you take a lymph node and you see the tumor under the microscope, there's not a lot of those tumor cells on the lymph node. There's a couple of those tumor cells, but there's a lot of immune cells
Mm.
around those cancer cells, and a lot of the bulk of that tumor is actually made up of inflammation and immune
Mm.
mediated cells and so forth and so on, and that's actually very relevant for the treatments that we have available nowadays.
Okay.
So we have 5 types. We have 4 types that are called classic Hodgkin lymphomas that are the most common ones,
Hmm.
and there's another one that is called nodular lymphocyte-rich Hodgkin lymphomas that are actually they look a little bit more like a indolent non-Hodgkin lymphoma, but be as it may, is on that category right now.
Okay.
Things that we have to know about this: they usually present like lumps or masses that usually they begin on the neck or on the above your clavicles, and then it can spread in the other lymph nodes, and sometimes outside the lymph nodes, like in the bone marrow, the liver, the bones, etc. It's more usually that we see it in young patients between the ages of 20 to 40 years old, but we also have another peak after 70 years as well. It's a
Okay.
very curable disease, even if it's stage 4. Okay,
Okay.
and the interesting thing about it is a very rare lymphoma, if
Mhm.
you look at it as a whole. But that field of Hodgkin lymphoma is rich of multiple, well done, well controlled clinical trials that have answered a lot of questions for our patients and, of course, for us, and has moved the field forward in a very, very amazing way. Very amazing way.
Good. That's
Okay.
great.
Mhm. Then On the other side, in non-Hodgkin lymphomas, like I told you, there's a lot of different things. So let me start with the B-cell non-Hodgkin lymphomas. The most common one is that diffuse large B-cell lymphoma. Why we call it like that? Because when we look at it under the microscope, we see multiple different cells that are very big lymphocytes, and then they divide very fast. Okay, when there's multiple types. So there's another one of those diffuse large B-cell lymphomas. There's a lot of them, and we're going to talk about that in a minute. There's another one very characteristic, but it's only 2% of those non-Hodgkin lymphomas. That is called a Burkett's lymphoma.
Okay.
That is what used to be very common in children in sub-Saharan Africa and so forth. But nowadays we see it also a lot in this part of the world. At one moment in time, in patients with that were living with HIV and AIDS. But nowadays, even in immunocompetent patients, it's a tumor that grows very fast. Actually, it's the fastest growing tumor in all human biology. Okay, it can double its time in 24, 48 hours sometimes. So, but it's very curable with chemotherapy as well. And the cells are very small, but they're all over the place. That's another type of those aggressive, fast-growing lymphomas. In the indolent lymphomas, there are a lot of them. I can talk to you all day about those. But the most common ones are these follicular lymphomas, okay? That they're usually very localized on lymph nodes, multiple parts of your body. And if you see on the microscope, they're usually small to intermediate sized little cells that actually they resemble in a lot of ways the normal architecture of a lymph node. Okay, but there have some pathological characteristics that make them grow, and grow. And there's a lot of them. There's, for example, some of them that are called marginal zone lymphomas. They are very characteristically, they can be in a lot of different parts of your body. There's a very famous one that it's on the stomach sometimes. It's called gastric mild lymphoma that is related sometimes to infections with Helicobacter pylori. Okay, and actually this is interesting because sometimes what we do for the treatment of those lymphomas when they're very localized is actually we treat the Helicobacter pylori, and we can cure those lymphomas just with that.
Excellent.
There's another one that appears right next to your eyes and is related to some other infections. And those tumors are very related with chronic inflammation. So there's a lot of different ones of them. Yeah. And another thing that I want to point out is that one of I don't know if we're going to talk about risk factors, but some of these lymphomas can arise in people who have a low immunity, either low grade, but especially high grade lymphomas, like people with uncontrolled HIV, AIDS, or after transplant, either solid organ transplant or bone marrow transplant, and so forth and so on.
Oh, okay. Yeah, that's interesting. So, I know you did mention some symptoms, but what are the common symptoms of lymphoma, and how does that change with the different types of lymphoma?
Correct. So for all lymphomas, the most common symptoms that we see is that patients, especially in general, talking about something that overlaps between Hodgkin lymphoma and non-Hodgkin lymphoma, it's just simply like enlarged lymph nodes. Okay, they usually are painless enlarged lymph nodes, and in areas where the skin is very thin, and so you can see those lymph nodes actually more. They're more noticeable to the patient. Let's say, for example, on the neck, on the armpits, on the above your clavicles, or actually in the groin area. Those are the most common symptoms. However, there are some other symptoms that are classically characteristics of lymphomas. We call it "quote unquote" B symptoms, but nowadays we call it more constitutional symptoms. What are those? The classical ones are profuse sweating, profuse diaphoresis. So we call it diaphoresis is sweating, especially in the middle of the night. Ongoing weight loss, and the classic thing is more than 10% of your normal body weight in the last 6 months without trying. All right, not cheating, without trying, and or recurrent fevers by ruling any other causes, right? Ruling out infections and so forth, recurrent fevers. There's some other symptoms that are a little bit less specific. For example, fatigue, more fatigue than usual, and that we cannot explain otherwise. For example, in some cases of Hodgkin lymphoma, patients, and that's actually a little bit more common in that disease, patients complain of generalized itchiness or pruritus, we call it. Sometimes in Hodgkin lymphoma, especially in young people, You can see that if they have a lot of lymph nodes on the neck, especially, they have pain on the neck when they drink alcohol, or actually they can get also very itchy when drinking
Oh,
alcohol. Very uncommon, I can tell you that, but it could happen.
it could happen.
Um, Also, for example, if the lymphoma is invading the factory of blood, that is the bone marrow,
Mm-hmm.
uh, that's more common in some lymphomas than on others, but
Mm-hmm.
that can cause low blood counts if you get, and all the consequences that come with low blood counts. Easy bleeding, bruising, being more prone to infections, and being fatigued because of severe anemia and whatnot. So that is in general for lymphomas, right? The other thing, that because lymphomas, they can invade almost every organ on your body. So
Mm-hmm.
it also depends on the areas where you have involvement from your lymphoma.
Right.
For example, if you have a skin involvement, you're going to see nodules, ulcers on your skin, also local areas of itchiness. If you have involvement of your central nervous system, you can have focal neurologic deficits, even if it's localized on the brain, or a little bit more generalized, seizures, and so
Mm.
forth and so on. If it's in the gastrointestinal system, very on the gastrointestinal tract, very unspecific dyspeptic kind of symptoms, changes on your your bowel movements, bright red blood per rectum, bleeding, so forth. So it depends also where the lymphoma is actually invading. It's in what organ is involved.
Right. Right.
Mhm.
So there can be lots of different
Yeah,
symptoms, yeah, that
correct.
to look out for.
Mhm.
I know you mentioned risk factors. Is there anything that can increase or decrease the chance of getting lymphoma?
Excellent question, and that's something that a lot of patients access, of course, right? So I got to tell you that for the most part, it just comes, right? It's just uh, sort of like a spontaneous mutations or changes on the DNA or genetic code of those lymphocytes that they're termed then to be sort of quote unquote immortal and fast growing cells. For the most part, no triggers and no risk factors and so forth. Some non-Hodgkin lymphomas, like I told, we were talking about some of these indolent non-Hodgkin lymphomas, they might be related to some diseases, right? Some, especially some infectious diseases. We talk a little bit about some lymphomas that are associated with some bacterial infections, like Helicobacter pylori, or some chlamydia infections, and so forth. There's other, for example, there are other autoimmune diseases that are
Mhm.
related to some lymphomas, for example, rheumatoid arthritis, or Sjogren syndrome, that is related to some of these marginal zone lymphomas or mild lymphomas. Hepatitis B, but specifically hepatitis C, can also be related to some of these marginal zone lymphomas. For Like I told you, that's actually probably one of the most important risk factors are chronic immunosuppressed status of patients. For example,
Mhm.
in patients with HIV or AIDS that are poorly controlled, usually not in patients who are very well controlled HIV and living with the disease for years and years. Although they also have a little bit more of higher increased risk than other
Right.
folks, but especially on the ones who have uncontrolled HIV and AIDS, there are risk for lymphomas, especially aggressive lymphomas. Okay,
Okay.
uh, and also folks after solid transplant or after bone marrow transplant that are immunosuppression as well, there
Mhm.
are risk for that. In some instances, there are some other viruses that could be related to diffuse large to some of the high grade lymphomas, like Burkitt's lymphoma. One of
Mhm.
them and to Hodgkin lymphoma. One of them is called Epstein-Barr virus, or EBV virus. That is the one that we probably all have. That is infectious mononucleosis, right?
Mhm.
But in just in a minority of folks, that can develop into a lymphoma. Minority of folks, okay? And there's a very weird lymphoma that is called adult T cell leukemia lymphoma that we see a lot of in Asia and in the Caribbean and in the north part of South America. It's a T cell lymphoma that is related to another type of virus that is called HTLV1 and 2 virus. So there's some of them that are related to some risk factors, and there's some familiar clusters, meaning that in very rare occasions you can have a familial predisposition to have lymphomas, but it's really very uncommon. Okay.
Okay. Okay. All right. And how is lymphoma diagnosed? How do you diagnose that usually?
Yes. Usually, as like with any other cancer, the gold standard for diagnosis is a biopsy, right? We need to do a biopsy of the affected tissue. In the area of lymphoma, you will hear this all the time from hematopathologists. Those are the folks who actually make the diagnosis under the microscope, all right?
Yeah, right.
You see them all the time, and this is where the guidelines recommend. We usually prefer to do what we call an excisional biopsy, okay, of the lymph node. So taking out all the lymph node, right?
Okay.
However, when there are areas that are very accessible, for example, like the neck, like the groin, armpits, that's usually sort of like a straightforward. Okay, it's an ambulatory procedure.
Mm-hmm.
However, there are other areas that are not accessible to do a excisional biopsy. They can be very cumbersome and sometimes even dangerous, right? Especially when it's deep in the abdomen, pelvis, and so forth. So in that case, we could also, through the magic of our interventional radiologists, we also use some other devices that are called core needle biopsies, incisional biopsies. The one that we don't like to use, and I never recommend that, I try to repeat it if I have to, but sometimes it's what we have, is what we call fine needle aspiration, or FNAs, that we see in other solid tumors that is pretty good. In lymphomas, it's not that good because we not only see the lymphoma cells to make the appropriate diagnosis, but we also see the architecture or the things around the lymphoma to get to the right diagnosis and to implement the right treatment.
Right.
Mm-hmm.
Okay. Yeah, that makes sense. Okay. Can you tell me about follicular lymphoma a little bit? Go into detail about that?
Yes, of course. So follicular lymphoma. All right. So follicular lymphoma is it comes from B cells, right? So it's a B cell non-Hodgkin lymphoma. Okay. Follicular lymphoma is what we consider an indolent or a slow-growing B cell lymphoma, and it usually is about 20-25% of all B cell non-Hodgkin lymphoma. So it's not the most common one, but it's up there. Okay. It's usually a lymphoma that comes from cells from a part of the lymph node that they grow very slow. These cells, actually, if you track them down, they usually have the very particular mutations. There's a specific one that is called translocation 1418 that is very common in this type of lymphomas, right? And it sort of like expresses or push up the expression of some proteins that don't let the cell die. Okay, and a very famous one is called BCL2. But anyway, so this usually presents as a very indolent disease, very slow growing. The most common complaint of patients are just palpable lymph nodes. But you can also have, like we call it in some occasions, constitutional or B symptoms, right? That we spoke about before. They can involve sometimes the outer linings of the lungs or the pleura. So you can have fluid around the lungs sometimes, or inside of the abdomen that is related to follicular lymphoma. Or it can also go into the bone marrow. It likes to go a lot to the bone marrow, more or less in 40% of the times. It can go into the factory of blood, and then it can affect it. And then you have decreased blood count, red blood cell count. So you get anemia and low platelets, thrombocytopenia, and low white blood cells. Not that common, but that can happen. So important things about follicular lymphoma is that per se is not a curable disease, okay? But with the treatments that we have available nowadays, they are extremely effective to put these tumors or under remission, deep remissions, and those remissions can last for years and years and years. So some people are talking about functional cures, right? For example, if you have a patient that have other issues going on, right? Other comorbidities, right? Issues maybe with the kidneys, with the liver, and so forth. And it's a person that is, let's say, above 75, 80 years old or more, and they have follicular lymphoma. You can, in a lot of times, we can control very well the lymphoma, and probably that person is going to have other issues that person will have other issues, and they will pass without lymphoma multiple times, right? So that's what we call, in some circles, we're talking about functional cures, right? But we can tell the patient that, yes, you're totally going to be cured like that, it's not going to come back again. We cannot say that nowadays. All right. Um, I try to tell my patients that sometimes it's like those surfers, that whack-a-mole kind of thing that, you put it to rest for
Right,
a
right.
long time and then it will pop back, up again later on. And then you have to put it underground again and so forth and so on. Okay.
Okay.
And one very important point is that a lot of these patients will never ever need treatment, even if you're stage 4 disease, meaning that the disease has left the building, that has left the lymph nodes, right? And they're
Right.
involving other organs that are not the lymph nodes, like the bone marrow, skin, gastrointestinal tract. Some of them will never need systemic therapy, meaning immunotherapy, chemotherapy, and so forth and so
Okay.
on. So I guess that's the main points about follicular lymphoma that I want to bring up.
Okay.
Mhm.
All right.
Mhm.
That's interesting.
Mhm.
How about mantle cell lymphoma? Could you tell me a little bit more
Okay.
about that?
Mantle is one of the most interesting lymphomas, in my opinion, B cell lymphomas, and one that I am passionate about treating it because it is a very rare B cell lymphoma. Indeed, it's only 6% of all those B cell lymphomas, of all non-Hodgkin lymphomas, I would say. Um, but even if it's so rare, it has multiple clinical trials going on because it has a little bit of both worlds. It has a component of indolent non-Hodgkin B cell non-Hodgkin lymphomas because not every patient. That's a really big difference. Like from 10 years ago, not every patient with mantle cell lymphoma needs treatment right away. Okay, I have patients that I have followed with mantle cell lymphoma for more than 3-4 years, and they have not required treatment.
Great.
And but unfortunately, those are patients that up until today, we cannot say for sure that we have cured those patients, right? That we can definitely cure those patients. Some of them have these potential functional cures, but they are more aggressive than follicular lymphoma, usually. However, in the other part, when these patients relapse, especially after certain type of treatments, in the recent past, like 3 years ago, 2.5 years ago, it used to be extremely difficult to control their disease. And unfortunately, a lot of them, they pass because of their disease in quite a fast way. So they have bad things from both worlds in a way. So that's why we're very interested in keep on, finding out more and more how can we help those patients. And I can tell you in the past 3 years, 2 years and a half, the field of mantle cell lymphoma has advanced quite a bit.
Oh,
This
good.
is this is a tumor that can involve multiple areas of your body, all right? And it's
Mhm.
one of the lymphomas that if a patient presents with gastrointestinal symptoms, it's indicated to do an upper endoscopy or a colonoscopy, depending on what are the symptoms. Okay.
Okay. Okay. That makes sense. All
Mm-hmm.
right. And I know you did mention this earlier, Burkett lymphoma. Could you tell us a little more about that?
Okay, we're going to strange grounds here. So
Oh,
Burkett lymphoma, so it's a very rare tumor. It's a very rare lymphoma in general, and it only is around 2% of all B cell non-Hodgkin lymphomas. All right, it used to be before more common in other continents like sub-Saharan Africa, very related in those continents to Epstein-Barr virus. Okay,
okay.
but we also see it here both in immunocompromised and in immunocompetent, meaning persons who don't have in immunosuppression kind of states. We see that we see it quite a bit. It is a B cell, very aggressive B cell non-Hodgkin lymphoma that grows extremely fast. Okay, it does not only involves lymph nodes; it has the tendency to do very big masses inside of the abdomen, and it has the unfortunate tendency to go to the bone marrow quite a bit and to go to the central nervous system, both the spine and the brain. So it is routine for us to, when we diagnose a patient with Burkitt's lymphoma, to do a bone marrow biopsy and to do a spinal tap or a lumbar puncture, right, to see if there are cells from Burkitt's lymphoma there. And we always try to administer some type of therapy through the spine or actually through your body to prevent for that Burkitt's lymphoma to go to your central nervous system because it becomes a little bit tough to treat. Um, So that is a lymphoma usually from a younger type of population. Usually they're diagnosed in folks that are less than 40 years old.
Okay.
Usually presents as an advanced disease, a stage 3 or stage 4 disease. But interestingly enough, before that, it used to be very common. One of the most common tumors in folks with AIDS, okay, with folks with very advanced HIV, that
Yeah.
the CD4 count, the T cells were very depleted, and so forth. Um, Nowadays, it's more common in folks actually who don't have HIV, because nowadays people living with HIV are very well controlled through their lives.
Right.
One interesting thing being that aggressive is that it's a quite curable disease.
Oh,
More than
okay.
70-75% of folks can be cured with very type of heavy load and aggressive kind of chemotherapy regimens.
Mm-hmm.
So for the most part, I strongly recommend, if a patient has Burkett lymphoma, they should go to an institution that has a lot of experience treating these very aggressive tumors, because that has been demonstrated in several multi-institutional trials and projects, that folks with Burkitt's lymphoma have somewhat better outcomes in institutions that are very experienced treating this type of aggressive lymphomas.
Oh, good.
Mhm,
Okay. Yeah, that's good to know.
mhm.
I think the last type we have is diffuse large B cell lymphoma. So could you share some more information about that?
Absolutely, and it's very, very important. And the good is for the last, right? So we save the good for last. So diffuse large B-cell lymphoma is extremely important because it's the most common non-Hodgkin lymphoma that we have.
Mhm.
It makes up around 60% of all the diagnoses of B-cell non-Hodgkin lymphoma. Um, and it's a tumor that is aggressive in its growth. It usually grows fast,
Mhm.
and it gives patients symptoms fast. And if we don't treat those lymphomas fast, the patient can be in great trouble. Okay, their health can be highly impaired.
Mhm.
So these tumors, for the most part, in more than 70%, 75% of cases, they are stage 3 or stage 4 disease, meaning that they're involving multiple nodal or multiple lymph nodes areas of the body. And in a lot of times, they're involving structures that are outside the lymph node, let's say the spleen, let's say the liver, bone marrow, and so forth.
Okay.
Uh, Once we do the diagnosis, we need to start treatment as soon as possible. There are multiple types of these non-diffuse large B-cell lymphomas. Some of them are very strange. For example, there's some that are only localized to the brain. All right, we call it primary central nervous system lymphoma. And some of them are more common, okay, and then some of them have mutations or genetic alterations that make them a little bit more aggressive and harder to control than other ones. For example, there's a common, not common gladly, it's less than 10% of cases, but one that is commonly known to be more aggressive than the other ones. Some of them are called double hit lymphomas. Some of
Mhm.
the other ones are called triple hit lymphomas. And those ones are very high unmet need in the field of diffuse large B-cell lymphoma. We need more and more clinical trials for those. More than 65, sometimes 70% or plus of patients can be cured depending on the stage of the disease, depending on the prognostic factors, and depending on the diffuse large B-cell lymphoma that they have. Cured
Mhm.
with what? With chemotherapy plus immune therapy. One medication that has revolutionized the treatment of this that is
Yeah.
called rituximab, that a lot of people know. Okay, it's a monoclonal antibody. However, if the lymphoma, and it depends how fast the lymphoma comes, the diffuse large B-cell
Mhm.
lymphoma, if it comes back, we still have a chance to cure it. It depends on how fast and how aggressive it comes back.
Mhm.
But we also have some other tools at our disposal that are very important to cure the lymphoma. One of them is a stem cell transplant, what we call autologous stem cell transplant from your own cells. And nowadays, one of the newest kid on the block is cellular therapy in the form of chimeric antigen receptor T cell therapy, or CAR T cell therapy,
Mhm.
right? That has been approved for patients with relapsed refractory diffuse large B-cell lymphoma,
Mhm.
mantle cell lymphoma, and follicular lymphoma. Okay, but
Okay.
especially in diffuse large B-cell lymphoma, we have seen excellent results in patients that before couldn't have any other viable therapies to control the disease and potentially cure that disease. Okay, so it's a very important. It's a field that is constantly growing, and that we're seeing a lot of advances right now for our patients. And there's a lot of clinical trials going on for that population.
Yeah, that's great. That is really
Mhm.
great. I know you did mention a number of different treatments, but can you just briefly tell me what the most common treatments are for lymphoma?
Absolutely. Let's just start with diffuse large B-cell lymphoma, right?
Mm-hmm.
That is the most common lymphoma. So in that, the most common, the queen of all treatments that I have been unbeaten for years and years and years in multiple trials is called R-CHOP. So it is a combination of immune therapy. That is
Mm-hmm.
the rituximab is a monoclonal antibody. It's not chemotherapy.
Okay.
That is directed against certain proteins outside of the lymphoma cell. In that case, it's a protein that's called CD20. All right. On the other side, and it's paired with a classic chemotherapy medications plus a steroid. Steroids are important to make the patient feel better, but they actually actively kill the lymphoma cells. Okay, so steroids are very important in a lot of our treatments. There
Mm-hmm.
are some other treatment regimens that are more aggressive and are
Mm-hmm.
using more aggressive diffuse type or aggressive B-cell lymphomas, like in Burkett's, that are given inside of the hospital in a lot of settings.
Mm-hmm.
And but they're not a standard of care. I would say that frontline the standard of care will be this R-CHOP.
Okay.
Okay, and then from when the lymphoma comes back, we already spoke about autologous stem cell transplant.
Mm-hmm.
And there's some other immunotherapies down the road, some medications that enhance the immune system, and some other new it's called antibody drug conjugates that are antibodies again, proteins that are directed against. I'm sorry, antibodies that are directed against certain proteins in the lymphoma cell, but
Okay.
they have attached to it. They have small payloads of chemotherapy that are in a way somewhat in a. We like to think that in a very intelligent and very directed way, very strategic way, delivers the chemotherapy to the bad cell. It's not always like that, of course, but they have proven to be somewhat transformational, very promising in this field. So in follicular lymphoma, remember the most important thing is to really know when to treat the patient because
Yeah.
not everybody needs treatment. If a patient needs treatment, there are multiple modalities of treatment. One of them is just if the patient doesn't have a lot of what we call high tumor burden, a lot of disease, but your oncologist wants to start treatment, that sometimes they can just use that immunotherapy called rituximab. Okay,
Mm-hmm.
but when you have a lot of high tumor burden or a lot of symptoms and we need to treat right away, the rituximab that is the immunotherapy needs to be added to chemotherapy, and they multiple ones of them. One of them is also R-CHOP, another is with a medication called bendamustine, and so forth and so on.
Mm-hmm.
If the lymphoma comes back, there's also multiple options. Right nowadays, in a lot of settings, we don't use the classic chemotherapy, right? We use a medication that enhances your immune system, pair again with a monoclonal antibody, being that rituximab or a new kid on the block for rituximab or the youngest brother that is called, it's a mouthful, but it's called obinutuzumab. It's a very long name. It's a little bit
Mm-hmm.
more powerful in some settings. So but it's a medication called lenalidomide, and the other one is obinutuzumab or this rituximab. Some people it can be used on the front line, initially, but it's more common to be used in later lines of therapy. And again, there's a lot of different therapies that have been approved for follicular lymphoma. A lot of them nowadays are actually oral medications.
That's good.
Some of them are called PI3 kinase inhibitors. That is a blocking agents for some parts of inside of the cell
Mm-hmm.
of a type of a clockwork that makes the cell grow and grow and grow. It's
Mm-hmm.
sort of like a blockage for that pathway. Um, there's some other cells like now recently a very personalized therapy was approved for folks with relapsed refractory follicular lymphoma that blocks a mutation that around 20 to 25% of patients with follicular lymphoma harbors, that is called the ECH2 mutation. That medication is called tazemetostat. So it's supposed to be very personalized for those patients. Very well tolerated. It's a pill. And however, we've seen that people with and without the mutation, they respond. So, but it's a very good option as well. And of
Yeah.
course, CAR T cells have been approved for patients with follicular lymphoma.
Yeah.
In the other hand, I'm gonna just mention briefly Hodgkin lymphoma. Hodgkin lymphoma, it's just amazing. The sort of like the personalization that we have for that disease, because we have different treatments for folks who have very early localized disease and what we call favorable risk disease. That is a whole other topic. In that disease is very curable. More than 85, 90 plus percent of patients will get cured. But where we're trying to put our efforts nowadays to decrease the toxicity of treatments. Okay, so that's one, and it's usually based on chemotherapy and a combination of chemotherapy and radiation therapy. But there are new things coming along the way as well. There's also some strategies for patients who have localized disease, but we have unfavorable risk features, very big disease, a lot of symptoms, and so forth. So it's also could be a combination of just chemotherapy with radiation, or actually just chemotherapy, but very short, abbreviated courses. Now, in the more advanced stages of Hodgkin lymphoma, there has been recently revolutions of treatment. For many, many, many years, more than 30 years, we use a combination of 4 chemotherapies. Nowadays, we use a combination. We still use that combination in a lot of different patients, but there's another combination that we can use, and it's extremely powerful and extremely effective in some particular high-risk patients. That is the addition of what we call an antibody drug conjugate. That antibody directed against a protein, but it has a chemotherapy payload on top of chemotherapy. It's proven to be safe and especially very effective. Now, when the Hodgkin lymphoma comes back, all right, we still have a good chance, more than 50, 60 plus percent of chances of curing the patient by putting them in on remission with another type of regimen and take them into autologous stem cell transplantation. Okay? But now the new things that are coming along are these, what we call, and you guys know it very well in solid tumors, that they're called checkpoint inhibitors, right? Checkpoint inhibitors like nivolumab, pembrolizumab, you name it. It's a whole bunch of them, right? They block these. They sort of like let go the brakes of the immune system, so the own immune system attacks their own lymphoma, right? And I'm going to tell you a secret right now that that's why I love treating lymphomas. These checkpoint inhibitors have the highest rate of effectiveness or response rates of all tumors up until now. Is Hodgkin lymphoma. Just with a single agent of either nivolumab, pembrolizumab, the response rate are more than 70, 75%, even 80% sometimes. Okay, and now we are pairing them with another type of chemotherapies, and now. So that's approved for later on when the lymphoma keeps coming back and back and back. But now there are clinical trials that taking that treatment a little bit earlier on the disease, and they're proving to be super effective. Okay, so it's a very exciting field, and more exciting that a lot of patients are getting much more effective therapies with less toxicity.
Okay? Yeah, that's great. That is wonderful. I think we have one more question. The question of the day. What are the benefits to enrolling in a lymphoma clinical trial?
Okay, the benefits are multiple, right? Multiple, because there's highly unmet needs in this population. Although I'm very optimistic, to be an oncologist, you have to be very optimistic, but we are curing a lot of patients frontline, but a lot of our patients are progressing, and especially in the area of diffuse surgery or aggressive B-cell lymphomas and mantle cell lymphoma. Once a patient has a relapsed lymphoma, high aggressive lymphoma, we are not very successful saving them and curing their disease.
Right.
So in a lot of these patients, and that's why we saw with the development of CAR T-cell therapy, we need a lot of efforts from our community, from our patients and their caretakers to participate in clinical trials. And I will argue that that participating in frontline clinical trials or things that that can readily cure with available therapies actually is very important, because this number that I'm quoting you, Fiona, is the curing about 65% of our patients with diffuse large B-cell lymphoma. That has been hanging steady for the last, I would say, 20 plus years. We're gonna see some new. I gotta tell you, this December is gonna be very exciting because we have new things coming. I think good things for our lymphoma patients, but it has required a lot of negative trials, right? A lot of trying and participation to get to where we are right now. And I do believe we can improve, but we need new ways to do that. And this becomes more critical, of course, in patients with lymphomas that they have come back over and over and over again, especially with new technology, therapeutic technologies, like something that are called, we already talked about CAR T cells, but some other things that are called NK chimeric cellular therapy, or bispecific antibodies that they try to emulate what CAR T cells do, but with infusions, and so forth and so on. There's a lot of things that we need to take into account for diseases that unfortunately still cannot cure. And the reality for indolent lymphomas is that we still cannot say that we can cure those diseases. So clinical trials with the effort to cure those indolent diseases, I think they're worth exploring, and it's worth for all of our patients to participate, and for all physicians to promote them in that sense. One last thing that I wanted to point out is kind of a pep that I always try to point out, is that a lot, and we did a project about this with my group, a lot of the patients that are enrolled on clinical trials of lymphomas, they usually don't really represent our diverse population of the US, okay? So the minorities, like in a lot of sites of a lot of parts of oncology, minority patients are severely underrepresented in clinical trials. So that's another thing, that we need to promote these clinical trials in our minority populations, like African American communities, Afro-Caribbean, Latin American, Asian American, you name it, right? So that's also an important population that we need to promote these clinical trials. Okay, I know it might be sometimes a little bit more challenging, but we need to make all the effort that we have to target this ethnic population.
Yeah, I agree 100% with that. I know we see that a lot in all of the clinical trials, unfortunately. So that's definitely something that, I'm glad that you brought up, and we should continue to represent, all ethnicities, and make sure that, there's a broad spectrum of people enrolling in these trials.
And another population that is very important in this, especially in lymphomas, are patients living with HIV. All right.
Yeah.
And I want to make the point that those patients who have been living with HIV for many, many years, who have a very well-controlled disease, should never, never, ever be excluded from clinical trials, right? And the National Health Institute and NCI, they have made some changes on that, and I'm glad to see those changes, but we need to be advocates for them as well.
Yes.
Right?
Yeah, I agree. So thank you so much for joining us today and sharing this information. It's been super insightful. And I have to say that, I'm happy to hear all of the good positive outcomes that patients are having. But I agree with you that we need to, promote clinical trials much more than we're doing. We're doing a disservice, really, by not promoting them. So we will definitely continue to spread the word and see how many people we can help with clinical trials. But thank you so much. I appreciate your time, and thank you for all the work that you do for cancer patients.
Well, you're very welcome, and thank you, Fiona, for having me, and thank you, Massive Bio, for the invitation. I will be glad to help with any other educational sessions that in the future if you guys need me. Okay, but thank you very much. It was a pleasure.
All right, take care.
Have a good day.
Bye-bye.
Bye-bye.